Recording. So within our chapter, we cross from Perth down to Tasmania and then across to New Zealand. And so it's a great opportunity for PhD students, other clinicians or academics or researchers to link in with a very collaborative group. I know we've done a lot of research projects together, and it's been great to sort of have that collaboration and also the ability to sort of mentor. We've got some very senior researchers within our group and down to sort of early career researchers and PhD students and clinicians. So it's a great chapter to be involved in. And one of the things is that we are part of the International Family Nursing Association, and so we can then use their resources, collaborate with them. And there's also been second yearly conferences. One of the main things that we really want to promote is that the conference for 2025 is in Perth. And so we're really hoping for sort of a great attendance of our Australian, New Zealand colleagues to meet with the rest of the world. Also, being involved within a larger organisation really gives us an opportunity for international collaboration and understanding how other countries internationally are really working with families to improve family outcomes. And the beauty of family nursing and the International Family Nursing Association and our chapter is it's not discipline specific, it is across the lifespan. So today we've got three great presenters, and you've decided on your order, haven't you? So Karen, you said you were going first. Oh. You hadn't decided on your order.
I don't think we decided. We're flexible, aren't we?
Happy to, though.
So rather than introduce you all at the start, I think I'll leave you to introduce yourselves and do a little bit about your actual research, because what we're hoping that today's paediatric family nursing, it really gives the information of how working in that paediatric environment, you can really improve and understand the experiences of both your paediatric patient, but also the family themselves. And so now I'll hand over to the first presenter to take the screen and start.
Was that me?
I think it is,
yeah,
Karen.
I think Karen, I think you've nominated yourself as first.
You go on, so, Karen.
Yeah, you can do it. I'm eagerly listening.
Right, you want me to test the technology, don't you? We'll see. Okay. So is that just my screen or is that notes as well?
No, that's just your PowerPoint.
Great. It looks like it's going to work. Okay, everyone. So I'm Dr. Karen Plummer, and I'm going to share with you today the evaluation of our nurse practitioner model of care for children with procedural anxiety. So that was led by myself and also our nurse practitioner, Kate Kotzer. So this service commenced as an urgent response to COVID-19, where we found that we just had this group of children, we could not get vaccinated. So a little bit about me. So I'm a lecturer in nursing at Griffith University. I tend to spend most of my time at Queensland Children's Hospital, though, where I conduct my research in the Department of Anaesthesia and Pain. I'm also currently an early career research fellow supported by the Kids Cancer Project. So I am doing pain-related research with kids with cancer at the moment. But I do have quite a long background as a clinical nurse consultant in paediatric procedural pain management, so quite passionate about that. So when COVID struck, I did have some requests from the media about preparing children for vaccinations and also some nasal swabs. Because when you think about it, like with COVID, it did add quite a reasonable procedural burden to children who, like if they were otherwise well, may not have required any vaccinations, any needles between infancy and adolescence. So whilst we saw that many children adapted, like this child here in the picture, so they could receive their routine health care, we did find that reality was that for a lot of families and clinicians was this, that children that we just could not get vaccinated due to significant procedural anxiety, and they really were at risk of missed healthcare. So this wasn't a new problem at Queensland Children's Hospital. We did have a study that had commenced prior to COVID, and it looked at whether an individualised collaborative approach for these needle-phobic children could have an influence on the rate of successful vaccination. And so no surprises, they did. The problem was that for these children, they did rely on more non-pharmacological interventions combined with 50% concentration nitrous or Entonox. So that required children to actually hold the mask themselves. So if kids are anxious, that's really hard to do. So we found that to actually get these children over the line, that we needed to combine oral sedation and higher concentrations of nitrous oxide. And so this was really reliant on anaesthetist to deliver, which is hard to access in the best of times, and let alone in a pandemic. So we did have, at Queensland Children's Hospital, we do have a full gamut of procedural care services that start with that standard procedural care, which is comfort, analgesia, language, mindfulness, your distraction, your topical anaesthetics. In that ambulatory care, like emergency setting, you can get access to nitrous and mild sedation for procedures. For those that are inpatient, you can have sedation to help with medical procedures, but it requires mostly medical input. And then we do have children at the other end that really we had to wait until they needed a general anaesthesia for something else to actually catch up their care. And so what we found was that for children with procedural anxiety, they might start here at that standard procedural care, but then they had to really kind of climb along that continuum. And what happened is that these kids, it often resulted in many failed attempts, which means children feel like a failure, and it often exacerbated medical trauma. So at our hospital, we saw when COVID came along, we really needed to look at this urgently. So we implemented a nurse practitioner-led model of care for these children that are more at that pointy end. And so it gave them an opportunity to get vaccinated with their required level of support immediately. And so we were looking at how we could bridge that gap. So really what we did was ultimately we added a specialist procedural care to our ladder. So this nurse practitioner model, it built on those individualised and coordinated care that we were already seeing in that specialist clinic, while also providing access to moderate sedation, so variable concentration nitrous up to 70%, plus oral sedation agents, plus our non-pharmacological interventions as well. So the model of care really, it started as outpatient medical day unit and predominantly for children require immunisation, but it did start to expand to that inpatient setting, and now they see children with a whole range of interventions that are required. Still predominantly a lot of these children do have procedural anxiety, but also now seeing children who are just having quite painful procedures. So one of the three nurse practitioners would call the families prior to the day of sedation and the procedures, talk about their triggers, their interests, so they could engage the children, and also preparing the parent for the impact of sedation. And then when they came on the day, the nurse practitioner would prepare the environment, prescribe and administer the sedatives, provide the non-pharm interventions, and we also had a proceduralist that actually do the procedure, so the nurse practitioner could focus on sedation. So although we could tell the service was going well, we were getting children through the procedures, we wanted to know, we wanted to evaluate the service because we actually implemented it so urgently. And we wanted to know, could we optimise it? Could we keep this service? So we used a hybrid type 3 design because we already had existing evidence that the procedural pain management strategies children were receiving were effective, they were evidence-based, but because we were responding in a pandemic, we were more interested in our implementation outcomes and how we could optimise this service. So for the effectiveness component, we conducted a prospective observational cross-sectional audit, and then any of those families that had been observed were invited to participate in an interview. and also the clinicians who've been engaged with the service to look at what were the barriers and facilitators to this service. So what we found, so we observed 40 children, and what was interesting was these children were older. They had that mean age of, nearly 13 years. And most of these children had a diagnosed anxiety disorder and or were autism spectrum, so neurodivergence. And mostly they were being referred for vaccination. And overall, we had quite a lot of qualitative data, 33 interviews, and part of that we managed to get 5 children to speak to us as well with their parents. So for the effectiveness evaluation, I developed the Paediatric Pain and Sedation Care Assessment tool. I based this on other observational studies I'd conducted with virtual reality, and we also used the efficacy outcome measures for paediatric procedural sedation to inform what key domains we were going to be looking at. So what we found was mostly it was the vaccination support, but really, so for these children, we're very happy with quite significant procedural anxiety. The majority of the procedures were completed successfully on that first attempt. And we needed for this to occur, all of these kids with sedation. We didn't have any adverse events apart from a couple of instances of nausea and vomiting, and it was also very timely. Even though these children were receiving moderate sedation, they were there for, less than 12 minutes on average and less than 4 hours in the hospital setting. So compared to a general anaesthetic, it was quite timely. So what we actually did was 85% of the children had topical anaesthesia. Those that didn't wasn't appropriate or would distress them. So all of the children had up to 70% nitrous. And then 95% also received oral midazolam and also 80% clonidine as well. So they needed those dual agents. All of the children received non-pharm interventions such as touch, guided breathing, therapeutic suggestion. In all of the audits, we had a quiet, dark, calm environment with one voice. Distraction was minimal. It just really wasn't working for this cohort of children. But most importantly, we had no forcible restraint. We also found that according to our FLAC scores on a 10-point scale, we had no to mild distress before. So children received oral sedation 30 minutes beforehand. So that definitely helped, but also very minimal distress during the procedure. And then afterwards, again, very minimal to no distress, which is important because children have long-term memories of pain. So it's important we end procedures well. So in terms of our implementation evaluation, what came out of our qualitative data was really that clinicians, family, everyone said that this access to moderate sedation was really a game changer. It bridged that procedural gap between the universal care and referral to theatre. So like as this clinician was saying, that they're also able to combine a lot more things that would have been held off until they're having a general anaesthetic. But before, there would have been a lot of pinning them down and getting things done and just making trauma worse. So there really only seemed to be a choice between going with standard care, which often involved restraining children, or waiting until they could access that sedation in a theatre environment, which was costly. And we also found that interesting, children said that it was access to moderate sedation that also really changed their experience. These children were really motivated to receive healthcare, which surprised me. But they all believed that they couldn't do it. So by having that access to sedation, by having that amnesic effect and not being overwhelmed by their emotions, they were telling us that they felt more in control. So really, ultimately, they had a good experience and it built their capacity to say, I can do it. And so like as this child shared that as a result of their experience, it was so weird because I used to be terrified, but now it's just like a walk in a park. And honestly, it kind of makes me smile that I'm able to finally, get vaccinated. And I would actually get quite emotional at the end of some of these procedures when I was observing because the kids were just so relieved, particularly with the COVID vaccinations. So even though sedation was key to the success of the service, it was equally recognised by all the participants that it was a whole environment where children had expertise in pharmacological, physical, and psychological interventions in a calm and controlled environment. So as this parent shared, is that we've had some traumatic experiences before because our child is difficult to cannulate, but now it's different. Going into the procedure room, one voice talking, guided meditation to keep her calm, not focused on actually being cannulated. And last time she even put her arm up on the pillow. So we're not holding her down. So this experience of children being restrained was really, it was very strong in this data. It featured in a lot of the interviews, and I found this quite interesting considering most of our children had a diagnosis of neurodivergence or anxiety, but families were saying that otherwise their anxiety was quite well controlled. It was hospitals and it was needles, and a lot of this was coming from prior physical restraint. So it was coming from the clinicians, as this child was saying, that they held me down, and that sort of started it from having a routine blood test to parents. This child shared that it was a parent that had held them down, and it was just like very traumatic, and begged them to stop. And that's coming from parents, wanting to get their child's health care and also being expected in those settings to actually restrain their children. And these children are just, these children are older, that parents are saying, we just can't keep doing this anyway. So the service was meeting the needs of, really children, families, clinicians, and who wanted an alternative to physical restraint. So we also found a key benefit of the service was meeting an unmet need in the community. So what was being offered was restraint or simple distraction, which just wasn't working. We also found like the children were saying, well, what they're offering me when they went to vaccination hubs was bubbles or other distractions, which were just childish. And they felt that no one really understood the unique needs of these children with procedural anxiety. Like this child, I needed to get vaccinated at school, and then started going faint. I was like really scared, and my friends were just like, dude, it's just a needle. But they don't understand that for some people, it's just like 1,000 times worse terror. People don't take it seriously. And so what we found was that, this service really provided an alternative pathway. Families were actually quite surprised that this type of service existed, and they had exhausted all known options, and they were exhausted themselves in trying to receive healthcare. They wanted it more widely advertised in the community, but the service needed to maintain that wait list capacity. That really the families and children too said that there need to be an increased awareness out there, particularly with GPs, as this child shared, that if they had have known, then people like me with the fear of needles wouldn't have to go through the stuff I had to before I was actually able to get the vaccinations done. So just before I finish, just some strengths and limitations. Just want to acknowledge we didn't do any formal psychosocial screening for children of their anxiety. I mean, it was an opportunistic study, and we took it at face value if we had a referral for procedural anxiety, that they did have procedural anxiety. Our sample size of 40, it was small, on the smaller side for the audit, but it was whatever who was referred to us in 6 months, that we did have quite a large qualitative sample. We didn't ask children to self-report, mostly because they were so anxious and also very sedated. And even though a lot of this data reflects immunisation, the service has expanded. But it was also really helpful to have observational approach to this. And also it was great to have that opportunity to feedback and inform our model of care as the service is being developed. And just, in terms of what we found, it was that we found that our model, it was clinically effective, it was safe, that we really need to consider, not just in this service, but more broadly, the need for developmentally appropriate procedural support for these older and more neurodivergent children that distraction may not work for, bubbles may not work for, and that this service is really meeting a need of children, families and clinicians. They're all telling us that there's just not the resources out there to help support these children who are so anxious. We also found that we really were reducing the risk of medical trauma in these children. So we were kind of reframing their experiences, but also demonstrating to everyone involved there was another way apart from restraining children. and also build everyone's self-efficacy in procedural care. But just before I finish, just want to acknowledge the Funding Australian College of Nursing, our wonderful research team, and our clinical services as well. And just leave you with, for those of you to consider wherever you're working, procedural care, just leave you with this quote of how much of what we do or fail to do now for children in pain will come to be seen as unwise, unacceptable, or unethical in another 40 years. Even though we've come a long way in procedural care, I think there's still a long way to go. That's it from me. Any
Thank
questions?
you, Karen. That was excellent.
Hopefully not
So
too long.
So Julie's got a question.
Yes, Julie.
I was trying to find the clapping emoji, but I couldn't find it.
Oh.
So I'll just go like this.
Thanks. I'll clap for you too.
We might move on because I was going to say we might do questions. Are you all right to stay to the end, Karen?
Yeah, I'm fine.
Yeah, because I thought we might do questions at the end just to make sure we get through everyone. So I'll hand over to, is it Mandy next?
Yeah, I could go next. What or Julie, do you want to go, or do you want me?
I can go. Yeah, I can go.
Yeah, okay, Julie, you go, and then I'll go after that. I'll be last.
Okay, excellent. Thank you.
Hoping that's doing what it's supposed to be doing. Everybody's disappeared. Can you see my slides? Yeah,
yes,
all good?
Perfect.
Yeah, Julie,
Great.
yeah, we can see it. Yeah.
Awesome, thank you. Hello, everyone. My name is Julie Blamires, and I am a senior lecturer at AUT here in Auckland, and I'm a child health nurse by background. And my clinical career and research career has focused largely in children and young people's experience of living with long-term conditions. So today I'm going to present an overview of an umbrella review that was 100% a team effort between the people on this slide, myself, Mandy, Shane Rasmussen, Maggie Zambo, and Evelot Morelia. So this is a little overview of our umbrella review, if I can get my slides to move. So just as a starting point, I guess most of us here will be aware that research around children living with long-term conditions has grown exponentially, and there's it's fairly good knowledge that families who have a child with a long-term condition manage really complex care requirements. They happen to negotiate across multiple healthcare teams, appointments, incorporate often unplanned hospital visits, while also adapting to the emotional load that an illness in a child presents. So families living with a child with a long-term condition also incur financial costs. And as pediatric nurses, we would always approach a child and family with a family-centered care approach. And so that means including the entire family, also including, hopefully, the healthy siblings. But what we know is that sibling relationships, although instrumental in the development of identity and a sense of self, even without the complexity of a long-term condition, are really important. That siblings in families where there's a child with a long-term condition can have some significant impacts on their life, which may not always be sort of top of our mind. So a long-term condition is defined as any ongoing long-term or recurring condition that can have a significant impact on people's lives. This is the definition that we used. And of course, there's other terms that are used: chronic condition, chronic disease, or chronic illness. I believe the politically correct term is now long-term condition. So I guess, yeah, as a starting point, that was our terminology. So the impact of having a sibling with a long-term condition, there's certainly some literature out there around the impacts. And what we found in our kind of initial search was that actually there's a lot of contrasting findings. So there's papers that talk about, you know, the negative impacts, including mental health impacts, depression, low self-esteem, the also effect on sleeping and school, etc. But there also are a number of papers that talk about the positive impacts, such as, you know, building resilience and the fact that siblings are exposed to unique situations that other children are not privy to. So these can be positive or negative, and that's really where the literature sort of sits. What we did find also initially was that much of the research, and if any of you are child health researchers, this will be a familiar concept to you. Much of the research is very focused on parent proxy reports. And Chudley and all in 2019 were really critical of these studies and described how important it was that we listen to the authentic voice of the sibling. And so it was on that note that we based our study, where we wanted to focus on really highlighting the papers that really gave a voice to the young person. So we thought we would do an integrative review, and we did an initial search and found in the last 5 years there were a multitude of systematic reviews, integrative reviews, scoping reviews, et cetera, well over 30 that had been completed in the last 5 years. So we decided to undertake an umbrella review. So for those of you who don't know, an umbrella review is a review of reviews. It compiles all the evidence from existing reviews on a topic to give a high-level overview. There are some guidelines out there on how to undertake an umbrella review. We use the JBI umbrella review methodology. I was going to time myself. Just yell at me, Elizabeth, if I'm going over time. The JBI umbrella review, I'm not going to go into details about the whole process because it was a lengthy one and a steep learning curve for everybody on the team. But what I want to highlight on this slide really is that we were most interested in those reviews that focus specifically on the voices of healthy siblings. So if we weren't able to extract the data away from parent proxy reports, then those studies were excluded. So we ended up with 11 reviews. And so there were a number, obviously, of primary studies within those reviews, up to 243 primary studies. There was a range of approaches that were used, quant, qual, mixed methods. Some of the studies focused specifically on conditions, so cancer, ADD, kidney, CF, and type 1 diabetes, whereas others took a more broad approach in their review, looking at studies from a range of different conditions. And there were a range of countries represented, and the age range we were interested in was up to age 24, and these studies were the age range was 4 to 24. So we developed 4 themes and 8 sub-themes. I'm happy to talk through with anyone at any point about the sort of process of undertaking an umbrella review using quant and qual studies. And I guess the very challenging process of coming up with a way to summarize what you found. This is the way we summarized our findings. So 4 key themes, and each have 2 sub-themes. So I'm just going to try and talk through some of those for you right now. So the first theme was about adjusting to changes. And there were these 2 ideas underneath that adjustment to change that had to do with disruption to routines and longing for attention. So the first subtheme really talks about the fact that, the siblings talked about significant disruption to their usual daily routine due to often the increased care needs of the child with the long-term condition, and how this impacted on their psychosocial, physical, emotional well-being. It also influenced academic performance, school attendance, and sibling and family relationships. The siblings talked a lot about in these reviews around how their social and extracurricular activities were often reduced, postponed, or sacrificed for the sake of their siblings' needs. And this sometimes had to do with the fact that there were high care demands, so the family were not able to attend or to leave the home even. And this healthy siblings often talked about how they understood this, but also still sometimes felt hurt by it. Interestingly, and I guess an area for future discussion, which I'll talk about at the end, was the impacts on school functioning, and that occurred across a range of areas, including siblings reporting decreased concentration, frequent absenteeism from school aversion, so just not wanting to go because they wanted to be at home or go to the hospital, and also relocation and changing of schools, and that was quite prominent in 2 or 3 of the reviews. So I think this is an important thing to make note of, is that there was an overall decline in academic performance, where they would, the sibling would say, oh, I want to miss school to visit the hospital, or, I have less time to do my schoolwork because I'm visiting, I'm with my sibling in the hospital. In terms of the second sort of sub-theme, longing for attention, it was really obvious that the family dynamic and the needs changed when one child in the family had a long-term condition. They reported, the siblings reported a disrupted family environment where family members were often separated. They had less time with their parents, and they perceived like a lower level of family support and cohesion, actually. So there was this shift of family attention or parental focus to the child with the condition, and that meant that there was less time for the healthy sibling. And again, this was particularly true in the studies where the brother or sister was in hospital. The healthy siblings also talked about how they felt that their parents overprotected or overindulged the brother or sister, that they tolerated bad behavior to a greater degree, and that they had more engagement with their with the sibling who had the long-term conditions teachers rather than with theirs. On the flip side of that, to meet sort of the changing needs of the family, the healthy children did adjust to their new role, and they developed greater independence. They developed some new skills and responsibility, and there is this sense of them being more mature than other children of the same age, and the siblings themselves reported that. So theme 2 was about how the healthy siblings yearn to be more involved and have knowledge about their siblings' condition and treatment. They wanted information about, the treatment, the progress, what the prognosis was, mortality, and a number of the reviews had siblings that really felt they weren't as informed as they would like to be. And they talked about the fact that they wanted to hear this information from healthcare professionals, just like their sibling did and their family members did. But they did feel often quite overlooked or not paid attention to by healthcare professionals. And so not knowing led to confusion, misunderstandings, they felt left out, neglected, and it also then created anxiety. And there was a repeated finding that siblings desired more comprehensive information at a much earlier stage. It was perceived, this information, as being really helpful to reduce fears and uncertainty. And that could be around, interestingly, Karen, including fear about needles. They'd seen their sibling having lots of needles. They had fears about developing the condition themselves, and also around, relieving some anxiety around what to expect in the future. Siblings also wanted to be included in the treatment and care decisions. They felt really distanced when they weren't allowed to attend the hospital, for example, if there were restrictions. And so this kind of made the siblings feel they kind of they withdrew and withheld their own feelings. They didn't want to bother their parents. They realized their parents had a lot to deal with already, but they were really aware of this kind of disconnection that was happening. They also talked a lot about formal support services and social and emotional support from family, friends, and teachers, and the important role that formal support groups for those who had attended them really held for them. Theme 3 was around well-being, but also the sense of feeling a bit isolated and lonely. The siblings reported a lot of worry and fear for their siblings' future, and it impacted their mental health. So there were some significant findings around emotional behavioral functioning, mental health and adjustment, and PTSD that were reported by the siblings. Interestingly, I guess, and not too surprisingly, that younger siblings they tended to experience more emotional and behavioral difficulties, while older siblings reported a greater impact on their mental health. And that's likely, because they are able to articulate that more clearly. In terms of the isolated and lonely sub-theme, they often reported feeling that they were often alone at home. They felt alone at school and also amongst their peers because they were kind of different and having a different experience. Often there were a few studies that talked about returning home to an empty house because the parents weren't there. They were at the hospital or at appointments. But interestingly, they also felt isolated from community and neighbors, because whenever they talked to neighbors or family friends, all the attention was about the ill child. And they recognized that, everyone was concerned with their ill sibling, but actually they wanted to feel comforted and acknowledged as well. So the final 4 around theme around living the changes. So after the initial sort of shock of the diagnosis, siblings did have some jealousy around the attention the ill sibling received, but there was a really strong thread that they developed good coping skills and resilience. And even though there was this kind of strained sibling relationship at times, overall, the healthy siblings did start to take on responsibilities for their siblings' care, and they had an overwhelming sense of concern for their well-being. There was also some interesting findings around the siblings reporting that they were the social glue of the family, and they felt, again, a strong sense of responsibility for maintaining family harmony. So the summary really, and there's so much more to say. There were a lot of findings in the study, but it was the first umbrella review on healthy sibling self-reported experiences. Certainly my first umbrella review. It highlights the complexity of siblings' lives and this notion that, which I didn't talk a lot about, but the fact that siblings do take on kind of parent-like caregiver roles. I'm very interested in the negative impact on school functioning, and I think there's some work that could be done in that area. Siblings want to be informed and they want to be present. And, this notion that the effect is negative and positive is something as healthcare professionals that we really need to think about. So in terms of practice implication, there's obviously a need for some, developmentally appropriate, age-appropriate information about conditions that we can provide for siblings, as opposed to always focusing on the family, wider family, and I guess the child themselves with the long-term condition. I think there's definitely some need for more, just looking at educational interventions, the role of support groups, and I guess as healthcare professionals, just be cognizant of encouraging participation. So don't forget they're there and that they have they're feeling all the feelings as well. So providing opportunities to have fun and strategies for coping. And, looking at our visiting policies, the sibling should be able to visit. And I think most places, they 10 in New Zealand and probably in Australia, but it was interesting the number of places where that wasn't possible. And I guess raising awareness about the impact on healthy siblings.
So just to finish up, I guess things to think about. We do want to continue some work in this area, and yeah, and I'm hoping we're all hoping to, you know, when we come to Perth in the new year, to gather together people who might be interested in doing some more work, looking at siblings, and whether these are just some of the ideas that we've had in terms of where we might go with this. I mean, one of the other things I'm thinking that will be quite important is to actually ask siblings what they think we should be doing research on. That may be our starting point. So yeah, so whirlwind tour of our umbrella review. It is published. It's in our reference list, which there's a lot of references there. But you know, happy to share the article. And also happy for anyone who might be interested in doing some further work looking at siblings experience. And I think that's me.
Thank you, Julia. That was really good. And you know, it's so true, because yeah, we know that, I know in my adult, I've sort of done interviews with the children or in the adults of cancer. And they definitely felt all of the above, that sense of not knowing, working through it, being left out of conversations, you know, and that sense of everything was all about whoever was sick, as opposed to there was never a question of how are you going. It's like, how's your mum going when they're at school? Teachers ask that. So it was this sense of constantly being reminded that your mum or your dad is sick, which does not help.
No, no, thank you.
So excellent. That was great. And it was good to see the recommendations on both your slides and also Karen's. I think that's a great aspect for people to sort of think about as they sort of, you know, whether it's researching or just talking to clinicians at conferences. So now I'll hand over to our last presenter, Mandy. We are going to go a bit over time, but I think hopefully everyone is happy with that, because we've had some great presentations.
Brilliant. I'll just share my PowerPoint. Yeah, can everyone see that?
Yep.
Thanks, Mandy.
Brilliant. So this was a project that was undertaken as a student scholarship project with the AUT Child Health Research Cluster. So we had a postgraduate student from physio, and then we also had 2 members from the University of Otago Postgraduate Centre for Nursing Studies. So it is actually 2 studies, and I'm presenting both really. One's been published and the other one is under review. So we were looking at children and young people's participation and decision making within healthcare organisations within New Zealand. So there's an integrated review which looks at peer-reviewed published manuscripts, and then there was also a Qualtrics survey that was sent out to nurse leaders within Aotearoa, New Zealand. I don't think that's moving. Oh, it is slowly. So, I mean, we all know, or we should know, about the United Nations Convention of the Rights of the Children. I mean, it's a very iconic, you know, sort of piece of document that's been ratified in numerous countries. But within New Zealand, we also have the Children's Convention Monitoring Group, the Deputy Chief Executives, and the Human Rights Commission, which are also looking at, you know, sort of making sure that the United Nations Convention of the Rights of the Child's document is actually operationalised within, you know, education and healthcare settings. So really incorporating children and young people's sort of into shared decision making within a hospital environment is rather problematic. I mean, everybody says that they're going to do it, but there's actually very limited literature, specifically within New Zealand and perhaps globally as well, in regards to children, young people self-reporting of shared decision making, you know, within decisions that are really important for them and that concern them, and that based on the United Nations Convention on the Rights of the Children, we should actually be doing. So this was an integrative review looking at the published literature within Aotearoa, looking at children's self-reported perceptions, so manuscripts or empirical research that researchers had actually engaged with children within hospital settings on shared decision making, but then also looking at, as we know, healthcare professionals and parents quite often by proxy report on, children's experiences within hospitals. So the theoretical underpinnings for this study was child-centred care, so that's Imelda Coyne, child and family centred care, that's myself and Linda Shields, that was therapeutic conversations in 2020, best interest of the child, Calverboer and Zulster in 2006, Ron Fernabina's bioecological model of human development in 2004, and of course, United Nations Convention of the Rights of the Child. So our aim was to explore how children within New Zealand and young people actually participate in discussions and shared decision-making processes within healthcare settings. What were the barriers and what were the benefits to such participation? So we looked at 4 databases, Sonal, EBSCO, Scopus and PsycInfo, but we also included academic and government and institutional websites within Aotearoa. The inclusion criteria was, because this has been published in 2022, was that it needed to be like a child's self-reported peer-reviewed manuscript in English or a document that was put up within a website. That also included potentially healthcare professionals' decisions and recommendations and opinions in regards to child self-reporting. We undertook inductive thematic content analysis, and all manuscripts and documents were critically appraised by the JBI tool. So you can see that this was rather a rigorous approach through the Aotearoa website search. So we looked everywhere for documents, and we did actually find 20, but there were only 7 that were actually met the inclusion criteria to be included for the review. You can see here, this is what we got through the different databases. And in the end, we ended up with 9 peer-reviewed pieces of literature. So 4 were from New Zealand children's self-reported experiences in hospital, and 5 were from adult proxy expert opinion. And then there were 7 from Aotearoa website organisations. So the included documents we ended up with, as I said before, 4 peer-reviewed manuscripts, and you can see what the citations for those. And we had 12 pieces of published evidence on adults' perceptions or recommendations, and that also included, academic websites and institutional websites. The critical appraisal scores for the child self-report manuscripts was 4 to 10, and for the adult proxy and organisational websites were 5 to 6. So what we ended up with was an overarching theme, a discourse on children and young people's participation within healthcare settings. We had 4 themes, being ethical considerations, service delivery, best interest of the child, and a child's understanding. And you can see there that's on each side of like the corner of the pie chart. That these are the categories. So for ethical considerations, respect, agency, research and competency. For service delivery, it was organisations and desires. A child's understanding was communication and information. And best interest of the child was a child's perspective, and child perspective, which is actually a parent adult proxy perspective, and then also participation. So ethical considerations, these were the particular areas or quotes really in relationship to this particular section. So researchers, when interviewing, allow for more than one meeting to assist with building rapport. And we know that we should all do this, but actually it's not very well documented within, well, globally really. And respect, recognising competent children not only supports ethical arguments regarding respect for children's rights and their personhood, it has other tangible benefits to both the child and healthcare services. Agency, of course, is about recognising that the child, you know, within all developmental stages and ages, are developmentally competent to be able to, pretty much from the age of 2, to have input into shared decision making. And it's really about how it is that we engage with children and how it is that we provide opportunities for children to be able to communicate with us. Competency was literally the child or young person's capacity in situation-specific areas, and will also depend on their experience with other healthcare experiences. So it's not really based on their age or intelligence. It's really about also looking at, like, you know, the other experiential sort of experiences that they've had and how that has shaped their competence to be able to respond to shared decision making. So service delivery is about the two areas where desires and organisations. So desires, she asks me, so this is a child. So for these ones, I've sort of tried to put a quote from a child self-report and then also a quote from an adult report. So desires from the child was, she asks me about my life, not how I'm doing, not just about my problems. When she asks me about my life, I know she's genuinely asking me because she's interested. And then organisation is looking at a survey that was undertaken within 2012 and 2013 with an Aotearoa, and it contained 7 questions about usage of public hospital services, but none of the survey questions were actually concerned about the children's perceptions of care received. So a huge gap, in adults sort of sending out surveys looking at children's decision making. So a child's understanding, communication, healthcare service providers should attempt to understand and make sense of children's communications rather than assume they do not make sense. And information was, children and young people have a right to information they can understand about their health and healthcare. This includes information about the choice of healthcare services available. Best interest of the child. So this is really when you're looking at the child's perspective, the adult perspective, and then participation. So the child's perspective is literally the child's voice, whereas the adult perspective is literally the adult perspective of the child's voice, and participation is pretty much what we really should be doing. So the child's perspective is that, you know, they're really wanting to have special attention in relationship to freedom to speak, to receive, and impart information, to be included, in areas that are concerning them, but also that's age appropriate and also individually, sort of targeted for that particular child's ability, competence, and desire. Adult perspective is that, in New Zealand, mostly children's views have been obtained, and they still are actually via proxy, given by adults such as healthcare professionals and parents. And so participation is really that we need to turn this around, and that there is an honest lack of opportunities in New Zealand for children and young people to participate in shared decision making within a healthcare setting. Now, this was the other arm of the study. One of our research questions really was the integrative review was really to then synergistically direct the survey that we were going to send out to nurse leaders within hospitals, being Auckland, counties, Manukau, Wellington, Canterbury, major hospitals, children's hospitals within Aotearoa, because we really wanted to explore nurse leaders' perceptions of organisational policies, guidelines and practices, and what it is that they actually did, their knowledge, what sort of things and strategies were set up in place to actually involve and enact children, young people into shared decision making within these hospitals. So it was a qualitative cross-sectional study. We had 11 open-ended questions that were guided by the integrative review. We sent out emails to 24 nurse leaders, and these were purposively sampled based on the areas and the size of the hospital, and so we ended up receiving responses from 8 nurse leaders, and we were quite concerned about whether we were actually going to be able to do inductive thematic analysis of these responses. But the responses were so detailed that we were able to do a thematic analysis, and we generated 4 themes, which was policy and guidelines, diversity, equity, inclusion, models of care, and inclusion of children and young people's voices. So nurse leaders felt really strongly that they wanted to include children and young people into shared decision making, and they had various means across the different hospitals, but it was very sporadic, and it was evident that there needed to be guidance within policy, I think, and also the governmental organisations that are actually monitoring, the United Nations Convention of the Rights of the Child and how that's being operationalised in Aotearoa. So the work that we have done is presently under its under its second review in child and child and young people's nursing. No. I can't think actually, but it's at the end of the presentation anyway. But once that gets published, we'll be sending reports through to these key stakeholders who can hopefully, sort of share some light onto and maybe do some further work really in regards to New Zealand. So here are 8 of the questions. There were 11 open-ended questions, just to give you a bit of an idea of what it was that we were, asking, which was quite varied. We were asking certainly demographical, characteristics of them as nurse leaders, but we were looking at policies and guidelines. Did they have like a child health consumer group? How is, the United Nations Convention of the Rights of the Child being implemented? What sort of tools were they using within their establishment? And then also looking at, guiding philosophical models or approaches of care within their facility. And also, how is it that they had specific initiatives and strategies, for vulnerable populations such as, sort of refugees, Maori, Pacifica populations. So we ended up with an overarching theme, which was providing a platform for engagement. And we had 4 themes under that: policy and guidelines, models of care, diversity, equity and inclusion, and children and young people's voices. So policy and guidelines, here are some exemplar quotes. And I do hope that we can share this with everyone once it gets published, because I think there will be further work needing to be done. But I think it's also a really important process that we've undertaken by the integrated review with, the literature, published literature, and then from the child and the parent perspective, and then also the guiding, sort of documents that has then, sort of created the questions to then ask nurse leaders, and could potentially be undertaken, well, in any country, really, I think. So the limitations and strengths. So for the review, the number of children and young people's self-reports were really small, which is concerning, very concerning. There were only 4. And most of the respondents were older children, therefore limiting younger children's voices. And we all know that getting ethics approval for younger children is very problematic, and particularly children who are in a vulnerable situation, being in hospital, being younger, critical care, palliative care. And these are the children that we really do need to be, sort of undertaking research with, not on. The results may have been influenced by the large number of expert opinion documents, and potentially biased amongst the research team, because we are very much into advocating for children and young children's voices. And international evidence was excluded from the integrated review because we were solely looking at literature within Aotearoa. For the survey, once again, international nurse leaders were not invited into the survey, therefore limiting generalisability to other countries. And another limitation of this study and also the integrated review is that we didn't consult with children and young people about our findings. So therefore limiting authenticity. So moving forward, I think like co-design, getting children on board, you know, as co-researchers, and I think it's a really important, you know, piece of research that needs to be undertaken. But however, like the procedure that we undertook with the review and the Qualtrics survey was very rigorous, and we followed a really, really systematic process. And there were numerous reiterations and numerous meetings with many of the researchers over this, with potentially, yeah, it was Julie and myself who pretty much led this project. Implications for practice and research is that, of course, we need to listen to children and young people, and we need to include them, be respectful, but also be cognizant of their developmental age and also competency, and provide ways in which we can include children and young people into, you know, sharing their experiences and letting us know, you know, how it is that we can do better or what it is that we are doing well. This also requires a multi-tiered collaborative approach. So it can't just be clinicians, it can't just be researchers. It has to come from government, it has to come from the nurse leaders, the healthcare professionals, and also family and children actually wanting agency. So we can't deem to think that, you know, what we're doing is what they want. But actually, when you look at the integrative review, that is what they're wanting. And when you look at like the nurse leaders reports, that's also what they're wanting to do. But there needs to be, you know, really strict sort of, well, not strict, but there needs to be strategies put in place where hospital and organisations are accountable for actually reporting and auditing on children and young people's, you know, sort of experiences in hospital. So the results of the review, may have health professionals, policymakers and researchers to understand what influences children and young people's possibilities and opportunities to participate. The barriers are described within the manuscripts, and the highlights definitely highlight the importance of supporting children and young people actually on multiple levels within multiple populations. And in essence, you know, we should always be including children and young people in anything that it is that we are doing with children, because then that's honouring the United Nations Convention of the Rights of the Child. So these are the publications. So one has been published in the Journal of Child Healthcare, which was part 1, and part 2, which was like the Nurse Leaders Survey, is under its second review in the Journal of Child Healthcare. Thank you for listening.
Thank you. And that was excellent. I think it was great that each of our presenters really sort of brought in a different aspect, and you can sort of see, I think one of the main things is that highlighting on the need to recognise the child's experience, whether that is the child as a patient, but or the sibling, but to really to bring that into our care. So I'll just open it up to anyone with some questions, and just really thank the presenters. That was an excellent view into sort of looking after children in acute care.
Thank you, Elizabeth.
Stephen, do you want to come on camera and ask a question?
Thank you very much for the wonderful presentation. My name is Steven from the University of KwaZulu-Natal, South Africa. I'm doing my PhD in developing a model of family engagement in the pediatric intensive care unit in Nigeria. So having listened to your presentations, which are very wonderful, I have the following questions. From the first presenter, a particular model for a nurse practitioner-led model for procedure. Actually, what I understand from the model is more of sedating children in a particular procedure in order to avoid unnecessary restriction. So, or restraint in the course of the procedure, which will make them more relaxed. Now, in a particular setting like the low-income countries, like most countries in Africa, where there are no health resources, especially advanced life support. And when you are sedating a child, you are likely to have you are supposed to have some advanced health support, like life support, like ventilators or some oxygen that should be there before you do the sedation. And if you are in the course of administering just a vaccine to a child, and instead of restraining the child, you are now thinking of sedating the child in order to avoid restraint. Now, if you don't have such advanced life support a gadget handy, I'm going to reconcile between applying this procedural model, not practitioner-led procedural model, and the availability of those advanced life support. That is my own question for the first presenter. Coming to the second presenter, I think we were talking about. Let me go to the last presenter first before we continue. We're talking about engaging children in communication, in decision making. Now, in some settings whereby due to cultural factor, especially like I always refer to Africa, where children are hardly found in the homeschool setting because they are, even when they want to go, they will tell them to go to school, and we hardly see them there because of the cultural norms. Because they believe that it doesn't concern them, they should just concentrate on their studies. So I don't know whether your study, your umbrella review, you are able to scope some literatures from this low-income country where you're able to find something, whether those students are actually engaged or your scope was limited to the high-income countries. And then talking about decision-making, participation in decision-making, the problem of now, we all know that children, they are in different stages of development, and at each stage, their ability to contribute or to think mentally and contribute in a particular mental stage is very important. So I don't know whether your review was able to bring about maybe specify the age. At which age do we begin to engage these children? Or is it that as far as they can talk, and even if they are maybe 1 or 2 years or 3 years, we should always listen to them, or there should be a particular age limit that we can start listening to incorporate them. And then we also know that before the age of 18, we always, although the American the American Convention of the Right of the Child encourage that we should listen to the children, we are also aware that the parents also should be involved due to the developmental stage that they have not reached to make decisions on their own. So how do we reconcile when a child is insisting that maybe he should be listened to, and then what the child is saying is maybe rationally or logically is not applicable? So how do we reconcile those particular age differences when it comes to decision making? I think these questions are for the last two presenters. Thank you very much.
Thank you. That is a lot of questions in one. I think we might go Karen first. You want to talk about the use of sedation, because I know that our hospitals are probably very much equipped with family rooms and spaces.
It's a very different environment, and that's why we did use moderate sedation, because we had the safety to back us up. I will say, Stephen, if you do want to, I can always put you in touch with Kate, who is a nurse practitioner, and she has spent a lot of time in Africa volunteering, so she'd probably have some really good recommendations, some practical aspects. But I would always say that, particularly these children, they had a lot of anxiety, they had a lot of negative procedural experiences. You can do really great procedural care with very little. And I think that should always be a first step. We know that there's a lot of simple evidence-based procedures that we can do before we need to resort to sedation. But of course, safety, when you're looking at this, I said this is a nurse practitioner service. They do have that advanced life skills to rescue a child if sedation doesn't go well. So yeah, it's a difficult balance between making sure children are pain-free and not traumatized, but making sure it's also safe. So if you'd like to, I'm happy if you want to contact me, I can share my email. I'll put you in contact with Kate. Does that help?
Thank you very much. Maybe you can share your email, then I'll write, then I'll be able to contact you later to learn more about.
Oh.
Excellent. And then I'll hand it over to you, Mandy, to talk about, because I know I've done scoping reviews with my PhD student who was also from Nigeria, and it was very difficult to find sort of evidence in those low and middle income countries.
Yeah. So Stephen, the integrated review that was done within New Zealand, so these were published articles within New Zealand, so it didn't include any other countries, and the nurse leaders were the same. But I have undertaken other research, integrated reviews, systematic reviews, looking at children and young people's and parents and healthcare's perceptions of involvement in care. And that's been published. It was part of my PhD. I've also done research on the best interest of the children, which was a study that was undertaken within Australia, looking at children's experience and desires of their best interest. That has included children, it's included parents and healthcare professionals. Julie and I are just analysing the data for the healthcare professionals manuscript. I've also undertaken research with researchers globally, developing a child research checklist that needs to be undertaken in child reporting, sort of activities with children. That was a big literature review, then a qualitative study, and then also a 3-round Delphi study. So children, it is I do agree with you that there are cultural nuances, and children, it may not be, like within their worldview or culturally appropriate for them to have a voice. But mum and dad may have a voice, if you know what I mean. But literally, I think you're looking at like child-centered care, where the child is foremost in everything that's being done for that child, so they're informed about everything. I don't believe that that is the correct approach. I think it's a child and family centered care, where the child comes first, but with consultation and communication with the child and the family. And if a child looks to a parent such as Pacifica and Mari in New Zealand, they talk through not only so much their parents, but it might be the chief of the village, the senior chief. So it's not like a one fits all, but the concepts, I think, are that we need to be cognizant of, and be respectful, and look at benefits and malefits and communication at children at all levels. So a child that is 2 can nod their head and say no, You know, you give them a spacer for asthma and you say, you know, how would you like to help? And then they might start playing with it. So it's not about giving a 2-year-old a big information sheet about their care plan. It's about engaging with them and building that relationship to hopefully have, you know, better health outcomes, better relationships. So children learn to trust and family learn to trust healthcare professionals. And it doesn't take huge, big screening tools. It's just about our approach, really. Does that help, Stephen, answer?
Thank you very much.
Yeah, and if you want to have a look at my research elements in AUT, or I could share that with you actually in the chat box, then you're more than welcome to connect in with me and I can share literature with you. I've been to Africa. I worked in Africa for a bit in Tanzania, Dar es Salaam. So yeah, it's a beautiful country.
Yeah, because I'm developing a model actually of family engagement, and actually family engagement in Africa actually concentrates on adult parents, siblings, and
Of
Yeah.
course.
we are finding it difficult to get to see how these children come together, but the literatures are actually not there. So I was thinking your own review was able to capture some things there also. So there's a wide gap there which I already were struggling with here. So that's why when I see your topic, I was thinking maybe something similar was must have done. So I believe we are all facing the same problem. However, I will just try to get your email and then
Yep.
reach
I'll put it in
whatever.
the
Yeah.
I'll put it in the chat
Stephen,
box.
why don't you ask some children as part of your study what
Mm.
they would like in a model of care, and then you can hear their voices.
Yeah.
I have a student who is working, who's from Malawi, and she's developing a model. Well, she's hoping to develop a model of care for children with cancer. And we did we did some, preliminary research around, well, she's actually doing a scoping review at the moment. And there's not a lot written from children and young people's perspectives in Africa. There's very little written. And so part of her research project, her PhD will be not only talking to parents, but actually talking to the children and young people as well to find out their perspectives. So adding to that knowledge base where there seems to be a bit of an absence. And just as a response to your question, we did definitely see in our umbrella review unstated a limitation of our paper was that the countries that were represented were, these were all papers written in English, and there were a number of countries that were not represented. And that was simply, we couldn't find any studies or reviews that had been done in certainly in sub-Saharan African countries.
And
Thank you.
it is, it's a huge limitation, Stephen, and it's such an area, such an important area that, you know, as Julie said, and I think I reviewed that PGR9, didn't I, Julie? And that's what I said, ask the children. Just include children. Yeah, it's all you need to do.
We might move on because I think we've got Kalpana, have you got a question as well? No, you just
No, Elizabeth. Actually, I just have a feedback because I was here from the beginning of the webinar and it was like talking to me because my PhD 100% revolved around the experience of siblings of children with chronic health conditions. And Karen, she's my supervisor, one of my supervisors, and I'm really happy and I was so impressed with the webinar. Thank you so much.
Oh, that's excellent.
I have
Yes,
told
and
Julie
Yeah,
about
thank
you.
you.
Yeah.
Yes.
I think it
Heard
worked
about
so
you.
well. The three presentations, they just really did blend into one another. And we have recorded it. I'll edit the recording and make it a little bit shorter because there were some people from Europe that had emailed Debbie once it had gone out via IFNA. So I'll shrink it down. I'll just check that's okay with the three of you before I send it out back to Debbie. But thank you very much. And I'm just go to the